Good evening, all the aspirants. The class will be taken by Dr. Naveen, sir, and the topic is Epidemiology, Class 3. So, you can start.
Good evening, everyone. So we will be starting the last part of the epidemiology, which is a very short class, but you can expect some 2 to 3 questions from this topic. So most of you will be knowing about the diagnostic test and how to analyze the diagnostic test. So I will not waste time. I will start it. See, if you have any doubts, just let me know then and there. It's a bit confusing at some point of time. Okay. So when you get a diagnostic test, this is a table 2 cross 2 table which everyone knows. This is constructed to know the sensitivity, specificity, the positive predictive value, and the negative predictive value of a diagnostic test. So how it is constructed is, sorry. Okay. So you make a 2 cross 2 table. Let us assume this is the disease positive, the disease negative. This is the test positive, negative. So once you run the test, some particular percentage of the patients will have a positive test. So that is A, which is true positives. So one who is having a true positive, we will be labeling it as A. See, the labeling can change, but make sure once you are remembering the formula as A by A plus C, make sure which is A, which is B, which is C, because most of the people get confused with this B and C part. So just be clear that how you are labeling that is what matters. So it is true positive. So true positive means that how much percentage of the patients with the disease are detected truly. Okay. So this is a true positive. So once we'll just see how the table is constructed, then we will move on to the individual variables. So view once the test and the disease is positive, it is A. When the disease is negative, the test is positive, that is B, that is false positives. When the test is negative but the disease is present, it is C, that is false negative, that the test is not able to diagnose it. So that is C, which is false negative. What is D? It is true negative. The disease is also absent and the test correctly identifies that it turns negative. So that is D. So what is the sum of A plus C is actually disease. So B plus D is the percentage who doesn't have the disease. Okay. So make sure that you remember this correctly, the A, B, C, D notation you're giving, only then your formula will be right. So we'll be further moving on to the test variables. So what is sensitivity? So sensitivity is the ability of the test to correctly identify individuals who have the disease, meaning that true positives. So let us assume that the total number of patients who have the disease is 100. The test identifies 95% of the patients with the disease. So the sensitivity comes out 95 by 100, which is 95% sensitive. So meaning that 95% of the time, the test will truly identify the patients who has the disease. Okay. So it is given by the formula by A plus C. That is true positives divided by true positive plus false negative, which is equal to the percentage of actually who has the disease, matlab disease positive. If you sum up of this, it is actually the patients who have the disease. The true positive is A by A plus C. Okay. So when do you use a highly sensitive test is that when you don't want to miss out the disease. For example, let us assume that a patient is having myocardial infarction. So now you will choose TROPE as a test because it has very high sensitivity that it will correctly pick up the patients who has the myocardial infarction. So we will be using the highly sensitive test when we don't want to miss up people with the disease. For example, TROPE and MI. Okay. So this is just an example. We'll be moving on. This example is the COVID test is 90% sensitive. It means that it identifies 90 out of 100 infective patients, meaning that the 10 percentage is false negative. That is that it will detect it will flag it as positive, but the patients will not be having COVID. So that's what sensitivity means. So now we will be moving to the next variable. Uh, the true negatives. What is true negative is the ability, specificity is the ability of a test to correctly identify individuals who do not have the disease. So when do you use a highly specific test? So for example, you are planning out an intervention on a patient. You should be doubly sure that the patient doesn't have a disease, then you will not do the intervention on them. That is when you use a highly specific test. So the test is given by the formula the true negative. True negative is D by true negatives plus false positive, which is means the total sum who don't have the disease negative. So that is given by the formula d by d plus d. A highly specific means few false positive. So if you have a highly specific test and it turns out to be negative, then means that we are very sure that the likely that the patient is not having the disease and we will not do that intervention on them. Okay. So if the cancer test has 95% specificity, it currently identifies 95 out of 100 healthy individuals, meaning that the people who don't have disease. See, basically, you will be tested with the formula whether you know how to calculate sensitivity, specificity. Okay, so just understand just remember the formulas as well along with that. So, what is positive predictive value? See, people often get confused between positive predictive value versus sensitivity. This is where people get confused. You can see the formula also. It is A by A plus B. Sensitivity formula is A by A plus C. So you just be very careful with the formula. So what is positive predictive value? Like you do the test on a particular patient and the test turns out to be positive. Now, what is the probability that the person actually has the disease if the test turns out to be positive? So this is very bit confusing. So I will give you a scenario. So there are 100, you go to a tribal population. So they don't have any two-wheelers. So they usually walk for a long distance. The chance that these tribal people having diabetes mellitus type 2 is very, very, very rare. You do a test on all the tribal population and the test gives 80% of positive test for diabetes. You know that the patients are unlikely to be diabetic positive. That is called as pretest probability because that they are usually walking and they're very thin and there is less chance that they have type 2 diabetes. But the test is giving 80% positive rate. That means there is something faulty in the test. Now we cannot be very sure that if the test is positive, it is whether the disease is there or not. So this is what the positive predictive and the negative predictive value comes in. So once what is the probability that the person actually has the disease? If the test is positive, then you will think whether the patient actually has the disease or not. Though there is an 80% positivity rate, but the population incidence, the prevalence of diabetes, it's less than one that particular percentage, then how can 80% of the test be positive? So now it becomes very less likely. So this is a positive predictive value. Now, what is the difference between sensitivity and specificity is that the positive predictive value depends upon the disease prevalence. If a particular disease is less in a community, it means that the positive predictive value will be low. Okay, so we will go on to the if the test is having a high positive predictive value, it means that it is trustworthy when it becomes positive. For example, if the test with high positive predictive value is positive, it means that the patient is likely to have the disease. So negative predictive value is similar, that it tells us that if it turns negative, what is the probability that actually he doesn't have a disease? Okay, is a probability that a person doesn't have the disease given the test is negative. So the formula is d by c plus d. The specificity formula is d by b plus d. So yes, people often get confused between these two: negative predictive value versus specificity and positive versus sensitivity. Just remember the formulas, which is the denominator. So when do you use a negative predictive value? The test with the high negative predictive means that it is trustworthy when it gives a negative result. The classical example is D-dimer test. So when the patient is having a problem, had a surgery. Now 5 days after surgery, the patient is having a unilateral pedal edema. Now what you do is that you calculate all the scores and then you decide. Then you do a D-dimer test. When the D-dimer has a high negative predictive value, meaning that if the test is negative, it is unlikely that the patient is going to have the DVT. So that is where the role of the negative predictive value comes. So again, it is influenced by the disease prevalence. So it is higher in rare disease where the most people are disease free. So for example, if the disease itself is rare and the test is negative, then means you are very confident that the patient is less likely to have the disease. Okay. So just summarizing what is the four variables. The primary difference is that the positive predictive value and the negative predictive value are extrinsic, meaning that it is affected by the prevalence. It is affected by the prevalence. So if the prevalence is high, the positive predictive value will go. If the prevalence is less, then the negative predictive value will go high. If the confidence is increasing. Sensitivity, on the other hand, sensitivity and specificity are not affected by the prevalence. They are the intrinsic property of a diagnostic testing. So this can be tested in your MRCP. Sensitivity and specificity are intrinsic properties where the positive and negative predictive values are extrinsic, meaning that they are liable to change with population to population, unlike the sensitivity and specificity, which remains the same in any population set for that particular test, right? So these are some definitions that I don't want to confuse you. Once you do the formulas, you'll be knowing it better, okay? So coming to the ROC curve. So ROC curve is receptor. Okay. See the ROC curve, what is designed is that for a particular false positivity, I want like we will compare the x-axis will be false positive rate and the y-axis will be true positive rate, meaning that whenever I'm having a low false, I want a test which is having a high true positive rate for a low false positive rate. For example, let us assume the false positive rate is 0.1 here. Now, for correspondingly, if I have a on the y-axis, if I have a true positive rate at 1, it meaning that when the false positive rate is low, the true positive is also the true positive is very high, meaning that the test is very, very good. So once you dot all these, like I'm just marking it in a dots. So once you connect all the dots and draw a curve, you can see that the blue curve has the maximum area under the curve. So it nearly it covers, this is the area of the curve, okay? So the blue line covers 95% of the area under the curve, okay? So it means that with confidence, I can say that if you use the test, it is the best available test that you can do because it has the 95% area under curve. But if you take this dotted line, this yellow line curve like this, it means that for a low false positive, it is again giving you a low true false positive, means there is a trade-off. Like it is giving the positivity rate is actually very less. So once, how do you select a diagnostic test is that if you plot this diagnostic test false positive and true positive in x and y axis, and then you just plot a curve, if you have the maximum area under the curve, area under the curve, you use those tests because that test is likely to have high sensitivity and specificity. Okay, so what can be asked is that if a test has highest area ROC curve, area under the curve, you use those tests. Okay, if it is less than 40, less than 50% of the area under the curve, the test is less likely to be a good test. So now let us. It is a bit confusing. And now the next topic is that what will happen when you adjust the cutoff values. For example, let us assume that these are diabetic patients. Okay. So now you use test with the RB. Now you want to do RBS values and make a define. You're using RBS to see what is happening. So you take RBS as 200. Just giving an example, 200. This is, let us assume this is 180. If you take 200 and you define that anyone more than 200, they will be called as diabetic. But in actual scenario, what is happening, even if they are diabetic on insulin, the sugar values might fluctuate. So if you take this 200, let us assume it is 200, this is 180, this is 160. So the blue, this curve, like, okay, this curve, I'm just drawing it on the curve. It represents the diabetes patients. Now, if you want to take this cutoff, let us assume that we are taking a cutoff of 200 to define diabetes. There's high chance that whoever is falling on the right of it, 210, 230, they're definitely going to be diabetic. There is no doubt. So this is called as true positives. Okay. So but the problem is that diabetic, if they are on insulin, they might have 180 also sugars. But if you are taking cutoff as 200, there is a chance that there is high chance that you are falsely labeling these patients as non-diabetic. So this is called as false negative test. This is true positive and this is falsely negative. So once you're increasing the cutoff, what is happening is that when the cutoff is increasing, when you're increasing the cutoff, the sensitivity is going to decrease and the specificity is going to increase. So instead of 200, if you take 250 as the cutoff to define diabetes, you are going to miss a lot of number of patients with diabetes. But if you get the test positive, you are very sure that the patient is having diabetes. So that is that sensitivity is decreasing and the specificity is increasing. Once you reverse this, once you decrease the cutoff from 200 to 150, there's high chance that you will be labeling a patient, a normal population, as diabetic, because normal population also can have a sugar of more than 160 at some point postprandial. Exactly at that point you do a test and you find out the cutoff is one, you make the cutoff 150, now you see it is 160, now you falsely label them as diabetic. But however, the sensitivity is going to increase, but the specificity is going to decrease drastically. So when will you lower the cutoff? When you think the disease is very detrimental, that you don't want to miss the disease, then you decrease the cutoff. Okay, so you just remember these alone. Okay, nothing else. These four columns, 3 into 2. Once you increase the cutoff, the sensitivity is going to decrease, but the specificity is going to increase. It is vice versa. Okay, fine. So MRCP, they might ask you, once you increase the cutoff, what is the result of the sensitivity and specificity? Fine. Just remember these two alone. Graphs, mostly the graph will not be tested. Just remember the table. So coming to the final part of the diagnostic testing, there is something called as Bayes' theorem, conditional probability. So what does it mean is that, see, I have a box in my home and I have two pets. One is dog, another one is a cat. Now there is something moving inside the box. Now I am having a doubt whether it is a dog or a cat. So if you assume a general probability, the chances of it being a cat is 50%. The chance of it being a dog is again 50%. So 50-50 chances. But I know my pets. My cat is very quiet. The puppy is very naughty and it often makes noise. So the evidence I have is that I know my nature of the pet. So since it is there is something is moving, but the cat is not making any noise. The pet is not making any noise. So by probability, I am saying that since it is quiet, the probability that animal being cat is high, it is 80%. Since it is quiet, the probability that it being a dog is very less. It is 30%. Now I am having an evidence. Now what I am saying is that with the general probability of 50, I'm inculcating this new evidence, and I will to make a further final conclusion that the probability that this animal in the box is going to be cat. Why? It is because it is silent. So the probability of that being cat is 72, that being a dog is only 27.3%. So what Bayes' theorem explains is that though you have 50-50%, which is a general probability, once you get a new evidence, you use those new evidence to increase the probability, like increase the confidence of probability. So now with this, I'm saying that the high chance that it is going to be cat. So this is Bayes' theorem, very simplified version. Now, how are we going to apply this in diagnostic testing? Okay, so we will be seeing that. Any doubt, just just give me a hint or stop me. So this comes the role of likelihood ratio. So what is likelihood ratio is that now I said that my dog is going to be naughty and it is going to be making noise. The cat, on the other hand, it is going to be silent. So this I know. So this is called as likelihood ratio. What in the likelihood ratio? It can be silent, and what is the likelihood? It can be with making noise. So something similar to that, there is something called as likelihood ratio in diagnostic testing. So what is a positive likelihood ratio? That is given by a formula, sensitivity by 1 minus specificity. So what does it tell is that how much likely a positive test in someone with a disease when compared to someone without disease. For example, you do a TROPE. So if the TROPE is elevated, the patient is less likely to have a myocardial infarction. So the chances that a TROPE will be elevated is higher in a patient with myocardial infarction rather in patient without myocardial infarction. So how can I given is that? So let us take a TROPE in myocardial infarction. A patient is coming to an emergency. Now you want the chest pain. Now you have a doubt it can be MI. So now you run a TROPE. So the intrinsic properties of the test are sensitivity and specificity. That sensitivity of TROPE is 90% and the specificity is 95%. So now I will calculate the likelihood ratio. Now that comes out to be 18. So how do I interpret a likelihood ratio is that a patient with chest pain and a positive TROPE is 18 times more likely to have an MI than not to have it. Okay, so this is how you interpret a likelihood ratio. Fine. So this is for a positive test, like once you are expecting a test. Now you want to, there's an inverse of the test called negative likelihood ratio. So now you'll go to how to use in a LR in a practice. So now estimate the pre-test probability. For example, now the patient is coming, let us take two patients. age 20, female. Another patient is coming, age 57, male, smoker, diabetic. So what is the, who will have the high pre-test probability to have MI? So this is going to be low, obviously, and this patient is having to have a high pre-test probability to have an MI. So now I will use the likelihood ratio as in the Bayes normogram. I will just show you the what is the normogram. So now with this, I will be changing my pre-test probability. Let us assume that both of the patients, this patient is A, let us assume this patient is A and this patient is B. Now I run a TROPI test and for both of them it is coming positive. Now how will I interpret this? Whether the pre-test probability is going to change or not. So this is the actual use of likelihood ratio. Okay. So I'll just show you an example. Fine. So just hope that this table is visible. So the left side shows the pre-test probability. Let us assume that patient is having a pre-test probability of 10%. Now what happens that I run a test with a high likelihood ratio. Let us assume that I'm running a test with a likelihood ratio of 50. So now once if that test becomes positive, let us assume that that as a test is a TROPI. Now that likelihood ratio is 50. For example, I'm just giving a theoretical example. Now the pre-test probability is 10. If I use a test with a positive likelihood ratio of 50, now the post-test probability is going nearly to be 85%. So if the test turns out to be positive, even though pre-test probability is negative, I will not send the patient back. For example, the same patient, young patient, female, now coming with chest pain, the pre-test probability is very low, 10%. But once the test with 50%, 50 times the likelihood ratio comes positive, the post-test probability is going to increase many-fold, which is 85%. Now I can say that 85% of the 85x, sorry, 85% the post-test probability that she might have an MI. I will not release the patient. So this is called as ruling in disease. So now I'm ruling in myocardial infarction. I will be doing further tests to confirm it. Okay. So now when this is a positive likelihood ratio, coming to the negative likelihood ratio. Okay. So it is given by the formula 1 minus sensitivity by specificity. Usually they will not be outrightly asking you the formula. So just remember the concept. So it tells how much less likely a negative test in someone with a disease compared to someone without. So just don't try to remember all this. When if you choose a test with lower LR, like that, the likelihood ratio should be less than 1. It means that that is what significantly reduces the probability of the disease. So for example, a patient, again a DVT patient is coming. We know that the sensitivity is 95 and specificity is 50. You see, the specificity is very, very less for a D-dimer test, meaning that it can be elevated in multiple other conditions. Once you put the formula of likelihood ratio, it is coming to 0.1. So if you get a negative D-dimer test, it makes PE very unlikely, especially if the pre-test probability was low. It's very, so coming to the normogram, I'm just showing this normogram again. So let us assume the patient is coming for a DVT or doing a DVT scan. The pre-test probability is 5. Now let us assume that the likelihood ratio is 0.2, negative likelihood ratio is 0.2. Now the test becomes negative. Now what is the post-test probability that the patient will have pulmonary embolism is 0.5. It is meaning that it is even more 10 times less than the pre-test probability. So this is how you use a negative likelihood ratio and a positive likelihood ratio. So once you calculate the pre-test probability, you use the likelihood ratio. If you want to rule in disease, you use the test with a higher positive likelihood ratio. If you want to rule out disease, you use test with a lower LR, lower negative likelihood ratio. So if it is less, even more it is going to be less likely the test is, the patient is having a disease. Okay. So this is how you use. There's a formula to remember this. Okay. So once you have how will you rule in and rule out disease? Fine. So these are the real life examples, like how with the most common test what we are using. I'll just explain this. For example, now you are taking a BNP value. You are running a BNP. Patient is, you do it for suspecting heart failure. The likelihood ratio, the positive likelihood ratio of the test is 15 is greater than 15, meaning that if the test becomes positive, the post-test probability is going to increase further. So let us assume that young patient is coming with short dyspnea. You do a BNP. Now it becomes positive, and you know that the likelihood test is 15. The post-test probability is also going to increase. So it meaning that though the patient might not have a heart failure, sorry, the patient has have a heart failure. Now you will rule in the heart failure, and you will search looking for the causes. You will search for the causes. You will not send the patient home. So when a high likelihood, you rule in disease. That is called as rule. You will rule in disease. When the LR is very less, for example, take this test, HIV combo. So once more test, what I will do is that D-dimer, I have explained D-dimer. Let us assume there is a antigen antibody combination test that is called as fourth generation DO test. If the test is negative, it means that very less like it is going to be negative in the patient. The patient doesn't have the disease. So this is called as negative likelihood ratios used to rule out disease. Fine. These are the two examples. Just remember like what is the concept. So once we do diagnostic tests to rule in and rule out disease. It is not a gold standard. That nothing is gold standard. You cannot say with a diagnostic test it is 100% it is the disease. It is not the disease. So you are going to rule and rule out the disease. So there is a mnemonic called as SPIN. SPIN is SP is specificity. ST specificity. Meaning that a positive test in a highly specific test rules in disease. What is SNOUT? SN is sensitivity, OUT is out, rule out disease. If a test with highly sensitive rules out disease. If a test is negative in a the test is highly sensitive and the test is still negative, it means that you are ruling out disease. Fine. So you just remember these two mnemonics. It will be frequently tested in multiple exams. SPIN. Specificity rules in, SNOUT, sensitivity rules out disease. Okay, you can also lose the likelihood ratio because the likelihood is also derived from the formula from sensitivity and specificity. So either you remember that or you remember this just sensitivity and specificity. Fine. So this is the same. Like if you want to rule in the disease, you use a test with high specificity and high LR ratio. Positive LR should be at least greater than 10. If you want to rule out disease, you use a test with high sensitivity and the negative LR likelihood ratio should be less than 0.1. Okay, fine. So this can be asked as an MCQ, potential MCQ. How will you rule in and rule out disease? Fine. Okay. So these are the real life tests. Once you suspect a pulmonary embolism, you rule a D-dimer just to rule out disease because the D-dimer has SNOUT. The rule out has high sensitivity. The specificity is only 50%. The sensitivity is around 95%. The specificity is 50%. So only with this you can rule out a pulmonary embolism. If you want to rule in, now you do a CT pulmonary angiogram. Obviously, it is going to be positive if there is a this thing. So it means that it is highly specific test. A pulmonary angiography is going to be highly specific for a pulmonary embolism. So once you just remember these, okay. This will be frequently tested. So this is a summary of the formulas, how to do sensitivity, specificity, positive, negative predictive value, likelihood ratios. You please remember at least for these four. This can be asked in the exams. So that concludes our epidemiology part 3. So most of the times you will be tested very superficially. They will not be asking you in-depth concept of what is Bayes theorem, what is the formulas for Bayes theorem, what is the pre-test probability, what will be the post-test probability, assuming that this is high. They will be just asking if the LR is highly high, it is more than 20, whether the post-test probability will increase or decrease. This is what they are going to ask. Be very thorough with the concepts, okay? So there are some 19 MCQs. I will be attaching this. You can do it at your own pace. I will give the answer as well. So if you want to, do you want me to do it now or you want to do it alone?
So we can do it on our own later on.
Yeah,
I mean,
yeah,
after.
because you have to do the formula, you have to understand the formula only, then it will be helpful for you. So
Exactly. We need to.
yeah, I can get your point. I have given the answers as well. So once you get them, you just do these formulas. Okay. There are 19 questions I have attached. Please do that. So any doubt in the sensitivity, specificity, or these things, make sure that you understand, because it is clinically also it is important that how the post-test probability is influenced by the likelihood ratio of a diagnostic test. And the diagnostic test sensitivity and specificity or the intrinsic property, they are not going to change even if apply for any population, but the positive and the negative predictive value will change according to the prevalence. That is an important question frequently asked in MCQs, MRCP. So when will you rule in disease? Snout and spin. Just remember this mnemonic. Ruling in high specific, ruling out high sensitive. Right? So this is a diagnostic test. Bayes theorem, this is just I'm given an example. And if you increase the cutoff, the sensitivity is obviously going to decrease. The specificity is going to increase. So ROC curve, if the area under the curve is high, it means the diagnostic test has excellent performance. That is what the meaning. If it is less than, the area is less than 50% of the graph, it means that the test is not good. So you don't use the test. So sensitivity, specificity, we have just given the formulas as well. I'll share this PowerPoint. Any doubt at this point? So this concludes the epidemiology. So epidemiology, I think how to do a study, how to analyze a study, what is the biases. So how will you do what is false type 1 error, type 2 error, what is the number needed to treat, number needed A error, absolute risk reduction. I think hope you all have some idea about it. So please go through it. You can expect some 6 questions in part 1 and 5 to 6 questions in part 2. Which test to use, whether with the mean, median, whether you will use a man-Whitney U-test, whether you will be using a T-square, T-test, student T-test. They'll be asking very superficially. They will not be asking you the formulas or the application of the formulas. They will ask which test will you do in this particular group of population. So I will share all the 3 PowerPoints. Please just go through the tables only. I have just given you only the most salient points. So any doubts in particular in this? So what just erase it. See, now you go, I just given a scenario example. Now you go to a population who's 100% vegetarian. 100% assume that non-vegetarian. There is a group 100, let us assume 100 non-vegetarian. Now what you're doing is that you're going and doing a vitamin B12 deficiency. You want to establish how many people are vitamin B12. So the chance that non-vegetarians being vitamin B12 deficiency is very, very low, right? Because they are going to take non-vegetarian liver, they will have enough vitamin B12. Now you do the test. You do the vitamin B12 levels. Now you found out that the test is coming, the basis of the test, you are saying that out of 100 people, you do the test and you found out that 30 people have less vitamin B12 less than the normal. Let us assume that 30% of the people turn out to be vitamin B12 deficient. Now I cannot accept this, right? Because I know that the 100% of the population is a non-vegetarian population, and the test is giving me that these people are deficient. 30% of the population is B12 deficient. Now I will be suspecting. Now there is some problem in the test or the population. You know that the test, then there is a problem in the test. So this is how the prevalence is going to influence the result. Now, if you know that the prevalence of the particular disease in the community, even if the test becomes positive or negative, you will have a doubt. It is logical, right? So that is what the positive and the negative predictive value comes here. So what is positive predictive value is that if it's a probability that a person actually has the disease given the test is positive. So for example, okay. So now they are doing HIV positivity. They are doing a HIV test in a population. HIV test in a population, and they are taking 100 sample, and all these 100, they never had any risk factors for HIV. Okay, they never had any risk factor, be it IV drug abuse or a sexual practices. Everything was clean. They never had and you know that the community is going to be negative. But the HIV test is giving you, saying that 40% are positive for HIV. Now you will have a doubt. You cannot go and say to that population that 40% of your community is HIV positive. Now that is fundamentally a wrong information you are giving there. Now you will have to suspect whether the diagnostic test is right or wrong. Since the prevalence of that HIV is low in that population, even if the test becomes positive, I will take it with a pinch of caution. Like I'll be very careful in interpreting the test. So that is a probability that a person actually has the disease, even the test is positive. So now the positive predictive value is here is very low. Like even the 40, it is giving us 40 percentage. Actually, it will be less than. Let us assume that there are only two people positive. The positive predictive value is going to be very, very, very less. It is going to be 1%. The positive predictive value is 1%, meaning that if 40 test turns positive, meaning that only four is going to be having disease, right? You're getting my point, right? Any doubt? Like if should I want to explain in some other way?
Okay, sir, continue.
See, meaning that, see, if you know that population and you're running a test, for example, there was no COVID in between 2023 to 2024, maybe which means there was no COVID deaths, or the incidence of COVID was very low. Now you randomly run a test and say that 100 out of 100 in your hospital, 80 is coming positive. Now you have to be very cautious in interpreting. You can't go and say that 80 patients at the hospital out of 100 are having COVID positive. Now what you will say that you will see the what is the positive predictive value, because the positive predictive values depends upon the prevalence of the disease in the community. If the prevalence is low, then the positive predictive value comes lower than that. So even if 40% is the actually the test is positive 40 positive, you will say that you use these formula. So the true positive is 40 divided by actually true positives by false positive, it will be coming around 100. So now you that it is 4%. It is 0.4. It will mean 0.4. So the positive test predictive value is very going to be very less. So now you have to be very careful in saying that. So this is especially true when you're running a any test like HIV test or a cancer test. If the positive predictive value is low, then you have to be very careful in interpreting. This is not an intrinsic property of the diagnostic test. It is going to be influenced by the prevalence. It is similar to the negative predictive value. For example, D dimer has a good negative predictive value. If it is negative, it means that less likely that the patient is having a disease. So this is how the big disease prevalence. It's very, very important. The disease prevalence will have an influence on positive and negative predictive value. The sensitivity and specificity are not influenced by their intrinsic property. Even if you apply in HIV positive patients, or in a HIV negative patient, the sensitivity is going to remain the same. So negative predictive is just a bit confusing. Once you read it alone and try to get the concepts, you will be understanding it. Any other doubts? So that's it. I've attached some questions. See, one lot of people, what the mistake they do is that they will put the A in the table as right. They will mix up this. They will put B here. They will put C here. They will D. But they will be remembering the formula for sensitivity as A by A plus C, and they will be doing the positive predictive values formula. So you just be very careful where you are assuming that. Just remember that A and B are in the upper column. So make sure that in the upper box, A and B's are there. It's kind of memorizing it, but just be very sure that where is A, where is B, where is C, and where is D, because you will not be remembering whether it is false, positive, true, negative. You will be remembering it as A by A plus C. So be very careful. So you will not be asking about the Bayes theorem. They will not be testing, but remember that the likelihood ratio will influence the post-test probability. This is how we actually use in clinical practice. If you take a test with low likelihood, like only the likelihood ratio is only +2, then the post-test probability is not going to increase it. But if you take the test with a higher positive likelihood ratio, say it is 50, then you cannot ignore that positive test. Like the post-test probability is going to be nearly 90 or 95%. Even if they are young with a tropi, you should admit them and you should work up them, because it is ruling in myocardial infarction. There can be a myocarditis, or it can be a dissection of coronary artery, or it can be hypercoagulable state and it is causing a coronary artery thrombosis. Anything can be a possibility, but still you have to admit the patient and then you have to this thing. So can we wind up this is the last part. Epidemiology is done. I will share the slides. Just go through it. We can expect some mostly combined with part one, part two, some 10 to 12 questions you can explain. You can expect. So can we wind any doubt and can we wind up?
Hello, aspirants. Is there any questions? Then please ask. And either then we should just proceed with the class. And thank you very much, Naveen sir, for the class. It's been an outstanding session. We will share the PPT with the aspirants. And if there will be any more questions regarding, or they have any thoughts regarding that, if there are any issues, then we can just take a session over there. Okay.
Okay, fine. Thank you.
Yeah.
So,
Thank you very much for all the aspirants for having and giving your time. Thank you very much.